Hello students, welcome back. We're going to start a new lecture today, Signal Transduction Part 1. We started on it last time, but we're going to continue with signal transduction. Today we're going to show you how epinephrine activates a certain tissue. And the tissue that we're going to use today is going to be the heart itself, or a cardiocyte, or a heart cell. Okay. Let's see where we left off last time. We started with this rectangle here is going to represent a cardiocyte or a heart cell. And we learned last time that within a heart cell there is a beta-1 adrenergic receptor. The beta-1 adrenergic receptor on a heart cell is a 7-pass transmembrane receptor. It is a 7-pass transmembrane receptor. So I'm going to put that here somewhere because it's kind of an important point. So this beta adrenergic receptor, or you can just call it a 7-pass receptor. It is a 7-pass, and it's called 7-pass because that membrane, the protein itself is a long chain, and it goes through the membrane. It traverses that membrane 7 times. And you can look, if we go back here and you look at this, you can see 1, 2, 3, 4, 5, 6, 7. A 7-pass transmembrane receptor. And all of our adrenergic receptors are 7-pass transmembrane receptors. They just differ a little, and we won't talk about those differences until after we finish signal transduction. Now, the chemical or the drug that binds to any receptor, if something binds to a receptor or it binds to a protein and it causes a physiological response, that's referred to as a receptor. And I'm going to do one thing here just to make a distinction. Okay. Going to make a distinction here so you'll understand. It's important that you understand this one here. So here we have any substance here. And if it binds to a protein, if a substance binds to a protein and you get a physiological response, the protein to which it binds is a receptor. In that case, the protein is a receptor. So this could be any agent here, any chemical. If an agent binds to a protein and there is a physiological response, that protein to which it binds is a receptor. The converse of that is if you have some agent here and it binds to a protein and it does not result in a physiological response, so this is going to be no physiological response, or it doesn't block any, there's no physiological response, then that protein, so here we have a protein, here we have a protein. In the second case, if there's no physiological response, the protein is simply called a binding protein. It's not a receptor, just a binding protein. is simply a binding protein. For example, if you take certain drugs that you take will bind to albumin in your blood. And so if you take, let's say you take 20 milligrams of a drug, and 10 of those milligrams just bind to proteins in your blood and block the action of that drug, and the drug can't go on to do what it's supposed to do. That albumin in the blood is not a receptor. Even though the agent binds to the albumin, the albumin is not a receptor, because the albumin doesn't lead to any cellular or physiological response. However, if that drug binds to a cell and causes that cell to produce new proteins or results in a physiological response, then the protein on the cell to which the drug binds, then that protein is a receptor. It's only called a receptor if it does something, if it causes an action or response. Does that make sense? Excellent, excellent. Okay, so the proteins that we're going to be talking about henceforth will not be binding proteins. They're going to be receptors. Okay. And here, our receptor is the beta-1 adrenergic receptor. Any substance or agent that binds to a receptor, we have a special name for those substances. We call these ligands. And so for the beta-1 adrenergic receptor, the ligand is going to be epinephrine. Epinephrine is going to be the ligand. And we talked about epinephrine. Okay, let's see. Should I do this now? Just so that you will know, I need to, because when you're reading your textbook, sometimes these words can confuse you. Okay, and I want to show you one other. Okay, I'm going to just draw here. I'm going to draw a receptor. Okay, here's a receptor. Now, a ligand can bind to a receptor, and if it cause a physiological response. So let's just put a ligand here. Okay. So this is a ligand. It's binding to the receptor, and it's causing a physiological response. Okay, so this is our ligand. Or you can have a situation, make sure everyone has that before I continue. You can have a situation where a ligand, draw the receptor again, a ligand can bind to the receptor and block the physiological response. So this ligand, the second ligand, is actually blocking the activating ligand. Now, a ligand that causes a physiological response, it can be an inhibitory response or an activating response. If it causes any sort of physiological response, that ligand is called several names, but we can call it an agonist. That ligand is an agonist. An agonist. So when epinephrine binds to the beta-1 adrenergic receptor, it activates that receptor. It causes a stimulatory and activating response. It is an agonist. Also, epinephrine can bind to beta-2 adrenergic receptors and inhibit those receptors, or inhibit the response, that sympathetic response. They're still called agonists because they still cause a physiological response. Okay, an agonist, for example, when a ligand, the question is, can you tell me what an agonist is again? When a ligand binds to the receptor, like epinephrine binds to the beta-1 adrenergic receptor, and you get increased cardiac output. In that situation, because epinephrine causes a physiological response, it is an agonist. Yes, that's anything that any ligand that causes a physiological response is an agonist. But if you think about it like this, epinephrine also binds to beta-2 adrenergic receptors. For example, like in your bronchioles, it binds to beta-2 adrenergic receptors, and that inhibits those. It inhibits the smooth muscles, and your bronchioles open up. That's still a physiological response. Even though it's an inhibitory one, it's a physiological response. So even in that situation, epinephrine would still be an agonist because it causes the physiological response. Make sense? Now, let's say you have a situation. Let's see here. Does anybody take anybody heard of tertbuterol? Anybody have asthma? Okay, there's this drug called tertbuterol, and what it does, it actually, if somebody has, no, that's not going to be the right one. Let's see what would be a good one. Let's do something like this. Propranolol. Propranolol is a beta blocker, and what it does, it'll sit on top of your beta-1 adrenergic receptor. Now, when epinephrine tries to come in to stimulate your heart, that propranolol is going to block that epinephrine, and then your heart is going to slow down. And so it's a beta blocker. So if someone has some sort of congestive cardiac failure or some sort of heart disease, and they don't want their heart beating or if they have angina and you don't need that person's heart beating too fast, you will give them something like propranolol. That way the epinephrine that's produced in your body can't bind there and speed up your heart, and that way that person's heart rate won't be so high and they won't need as much oxygen, and then the angina will subside. They won't have that heart pain anymore. And so when something binds to the receptor and blocks its action, that's not called an agonist, that's called an antagonist. So anything that blocks a receptor is called an antagonist.
So even though it's blocking it, it's still causing a physical response?
In this situation, yes, it's blocking a physiological response. That's a good way to think of it. And so I see where your confusion is. You could be thinking, well, since it's not causing a physiological response, how can we call it a ligand? But it's causing the absence of a physiological response. So we still call those ligands. So an antagonist. Let's say, for example, you have angina, and so if you have angina, or if you have tachycardia, your heart is beating too fast. And the reason your heart is beating too fast is because epinephrine that's produced in your body is binding to those beta-1 adrenergic receptors and causing your heart to beat too fast. And so what you can do, what the doctor will do, say, okay, what we'll need to do for you is give you a beta blocker. And so what he's going to do, he's going to give you something like propranolol. It's going to go to those beta-1 adrenergic receptors in your heart, block them. Now when epinephrine is produced, it'll go to the heart, but it can't bind to those receptors because propranolol is blocking it. Now your heart rate is going to slow down and you're going to feel better. And so anything that blocks a receptor is called an antagonist. Anything that activates a receptor or inhibits a receptor is called an agonist. And what you're probably thinking right now, I'm confused, Dr. Merida, because it seems like something that blocks a receptor and an inhibitor would be the same thing, but they're not. Because epinephrine on some receptors can be an activator, a stimulator of beta 1. It can be an inhibitor of beta 2. But a blocker, the blocker doesn't actually cause the physiological response. It just stops the true agonist from binding. And that's why we call it an antagonist. That's a real subtle point that you'll have to understand. A blocker and an inhibitor aren't the same thing. Because epinephrine on some receptors is an inhibitor, but propranolol can still block it. That's a real subtle point. Makes sense though, kind of? Okay. If you don't get it, you can come to my office and ask me about that one. But that's a really subtle point. Because a lot of students will mix up an inhibitor. Sometimes epinephrine can act as an inhibitor, but we don't call it an antagonist because it still causes the right physiological response. But if you put something on it, if you put a drug there to block it, then we call that a blocker or an antagonist. So an antagonist is also called a blocker. So that's why we get beta blockers and alpha blockers. An agonist can also be called an effector. In some cases, we call them effectors. Okay. Okay, that's all the background we're going to give you for receptors and ligands and agonists and things of that nature now. We'll come back to these later, but that's enough for now. Does this kind of make sense? I know that's a lot of information right there. Okay, very good. Let's go back now to, here we are. So, when epinephrine, which is, is epinephrine in this situation, is it a ligand or not? It is a ligand. Is it an agonist or an antagonist? It's an agonist because it causes a physiological response. And the physiological response from epinephrine is going to be a greater contraction of the heart. Greater contraction. So if someone injects your heart with epinephrine, your heart is going to beat more strongly. Okay? Everyone okay with me so far? Now what we're going to do, we're going to look at the signal transduction mechanism or the signal transduction pathway. There are a lot of steps that occur between the epinephrine binding to the surface of the cell and, and contraction of that heart cell. Okay? So let's look at that now. Okay, what's going to happen first? Okay, good, I have mine. So I'm going to get rid of these question marks for now, and we're going to fill those in with something. Whenever you have a 7-pass transmembrane receptor, they're always linked with these proteins. It's a trimeric protein, and by trimeric, it means it has how many parts? 3 parts. So this protein is going to have, this is not the best drawing, but we'll see here. 1, 2, 3. So as soon as that ligand, as soon as epinephrine binds to that 7-pass membrane receptor, that's going to change that receptor, and then this trimeric protein is going to bind to it. Now in this state, first the protein is inactive. So I'm going to put here, this protein is inactive, and it has, does anybody know what ATP is? Okay, y'all have heard of ATP. Why do we need ATP in our body? For energy, exactly. It's for energy. Now, ATP is adenosine triphosphate, and adenosine is one of the nucleotides. But in signal transduction, we have another nucleotide triphosphate. It's called guanosine triphosphate, but in this situation, it's guanosine diphosphate. Okay. Now, don't try to do this right here. I'm just going to show you something here. Okay. And so before epinephrine binds, you just have GTP in the cell. Let's see here. I'm going to do this. You have just GTP. You have this trimeric protein with GDP attached to it. Now when epinephrine binds, it's going to change. It's going to change this part of the protein on the inside, and this part of the protein is going to be telling the GTP, this trimeric protein, I'm activated now. There is something binding to me on the outside. And when that happens, then this trimeric protein here decides, it says, what I'm going to do, when it binds, it's going to move. Now it's going to bind to, it's going to move here and bind to the receptor. It's going to couple itself with that receptor. Everyone okay with what's going on so far? Let me repeat that again. When epinephrine is not bound, the trimeric protein is just going to be, with GDP attached, is just going to be in the protein, in the cell, not doing anything. It doesn't care what happens. But once epinephrine binds, that's going to change the inside of this receptor. Now this protein is going to go to bind with the receptor. So the first step in this process is binding of epinephrine. That's step 1. Step 2 is that the receptor changes. The receptor changes on the inside. And step 3 is going to be this trimeric protein is going to move to bind to the receptor. Number 1 or 2? Let's go through all of them again. So step number 1. Here's the receptor. Here's epinephrine. Epinephrine is going to bind to the receptor. That's step 1. Okay. Step 2, a signal is going to be sent to the inside of that receptor, and the receptor is going to change itself on the inside. It would be like this. There's no door, and I can't go outside. Oh, then you won't be able to see me. That's right, that wouldn't work. It would be like, that's not going to work. I just have to tell you. It would be like two people, like in a doorway. One person's in the door, and one person can see outside the door, and he says, "Okay, I see the sun is up," and then they tell the person on the inside that the sun is up, or something like that. That's a real stupid example, but I think you understand. Epinephrine binds to the receptor, and then the receptor has to tell the inside of the cell, "Hey, epinephrine is binding," because we need to get the signal to the inside. Does that part make sense? Okay, now the receptor changes on the inside to let the inside of the cell know that epinephrine is on the outside. When that happens, then this trimeric protein moves, that has GDP attached, moves and binds now to the receptor. That's step 3. Everybody okay with that? Now something is going to happen. This protein here has GDP attached, but GDP does not have a whole lot of energy. And so what's going to happen, this GDP, I'm going to make myself another copy of this here. Okay, you all can't do this on your paper. So we're just going to move this to the side right now, because I may need this one later, so I'm going to move it to the side. Just going to move it out the way. Now what's going to happen to the GDP on this protein, it doesn't have as much energy. And so we're going to change GDP, and we're going to give it more energy. And so instead of guanosine diphosphate, we can make it what? What do you think? Guanosine triphosphate. Now it's going to have guanosine. Now it's going to become guanosine triphosphate. Okay. Now now this trimeric protein has become activated. And before we continue, let's give a name to this protein. Does everything make sense so far? I don't want to.
So when GDP attaches, it
No, GDP is already there. Talking about the GDP protein. This protein. So let's do the steps again. Let's go. Let's put this one. I want to be able to auto. Okay, I want to grab this. So let's move this out the way. So once the receptor becomes activated, then this protein binds to the receptor on the inside. Okay. Once that happens, once the protein binds to the receptor, now you want the protein, this trimeric protein, to become activated. And it activates itself by losing GDP and picking up GTP. And so this moves away because it loses GTP. It's the same protein, I just drew it twice because I'm going to need that again. And now it becomes GTP, guanosine triphosphate. Now this protein is activated. Everyone okay? Okay. Now, before we continue, let's give a name to this protein. So I want to keep calling it the trimeric protein. And scientists have made this really easy for us. They said, wow, let's just make this process really simple. Since the protein in all cases has guanosine, a guanosine nucleotide on it, they said, well, let's just call this protein, let's just call it what would be the simplest name in the world for this protein? Anybody guess? Exactly, a G protein. Who said that? Wonderful. And that's what it's called. It's called a G protein. And G proteins are super duper important in signal transduction. And we'll talk about G proteins a lot. And G proteins have 3 parts to them, 3 subunits. And the names are going to be real simple, really simple. So we have here. Let me ask you something. The beta-1 adrenergic receptor, is it a stimulatory receptor or an inhibitory receptor? Stimulatory receptor. So this protein is called a G-stimulatory protein. A G-stimulatory because it goes with a stimulatory receptor. Make sense? So it has three subunits. We call this subunit G-stimulatory alpha, and it has G-stimulatory, what do you think this is going to be? Beta. Very good. You all already know this stuff. And then this one is going to be G-stimulatory alpha, beta, gamma. Exactly. I know some of you all should know that. I mean, especially if you're anybody in a Greek organization, you should know those things. Okay, so we have G-stimulatory alpha, G-stimulatory beta, G-stimulatory gamma. And so whenever you name protein subunits, they could have decided we could call it, bless you, they could have called them proteins G-stimulatory 1, G-stimulatory 2, G-stimulatory 3, but they decide, okay, whenever we have a protein that has more than 1 parts, we're just going to call the different parts by the Greek alphabet, alpha, beta, gamma. And so that's what you'll see that a lot. Okay, so let's go back and see where we are. And so we've done nothing new in a while, and so all we've done is name things. So this trimeric protein is called a G protein, and it has 3 subunits. And when it becomes activated, it gains GTP. It loses the GDP and it gains GTP. Have I lost anyone yet? Everything making sense so far? Okay, now the next thing that's going to happen is that this G protein, the only one you need is G alpha, G stimulatory alpha. And so what I'm going to do now, I'm going to separate these but I don't want to throw what I've done away. So I'm going to make another copy and I'm going to put it over here for later. And now what's going to happen, you're going to lose. You all can't do this, unfortunately. So I'm going to grab this here. Let's see here. I should have put these on different. Can't do this on paper. Okay, I'm going to get rid of, see, G stimulatory alpha. Oops. G stimulatory alpha is going to separate itself from the beta and gamma. And so we're going to lose. So when we're going to lose, once GTP binds, we're going to lose beta and gamma. Beta and gamma are going to go away because we don't need those anymore. And actually, I'm going to get rid of the name too, because we don't need the name right now. We have it somewhere else. So initially, we had G stimulatory, alpha, beta, and gamma. You lose beta and gamma. Now you have just G stimulatory alpha with the GTP. Now what's going to happen? The G stimulatory alpha is going to move along, and it's going to activate another protein. So we have another protein that's found right on the inside. Let's get a good color. Let's do this color. We have a protein that's found right on the inside. Put a little groove right there. Okay. Okay. We have a protein that's found right on the inside of the membrane. And what's going to happen? G stimulatory alpha is going to bind to that protein. It's going to bind right into that groove there. And then it's going to activate that protein. G stimulatory alpha is going to activate that protein. And now this protein is going to take, the job of this protein is to take ATP, regular everyday ATP, and convert it to a circle, a cyclic. Bless you. Into cyclic AMP. And cyclic AMP is it cyclizes, it's a circle. So once G stimulatory with the GTP is going to bind to this protein, this next protein, and this protein is going to convert ATP into cyclic AMP. And when we come back next time, we're going to find out what is the name of that protein. What is the name of that protein? Okay. So let's do a quick review. Step 1, epinephrine binds to the beta-1 adrenergic receptor. Step 2, the beta-1 adrenergic receptor becomes activated. Step 3, the G protein with GDP, bless you, binds to the beta-1 adrenergic receptor, the intracellular part, and then it exchanges GDP for GTP. The GTP then loses beta and gamma. The GTP G protein loses the beta and gamma subunits. The alpha subunit, which is the activated part with the GTP, goes and binds to this protein, which converts ATP to cyclic AMP. And when we come back next time, we'll find out the name of this mysterious protein and what happens next. Any questions? Yes. Exactly. What actin and myosin do, actin and myosin are contractile proteins, and what they do, they overlap one another, and so when the heart gets ready, so imagine that this is the chamber of the heart. My hand is the chamber of the heart, and my fingers are actin and myosin. And so what happens, and there's blood in here. And so when those proteins start overlapping one another, they go like this, and so it makes the chamber of the heart smaller, and it squeezes the blood out. And so that's what happens, and that's what we're trying to get to. And when we get there, I'll explain all of that to you. Okay. Any more questions? Excellent. Things make sense? Excellent. So we're going to stop here. No, I have to stop here.